video, so I'll just do. Hello everyone. We are at the local hospital, and this is a perfect example of the whole reason for this project you and I are involved in, how to conquer challenges. So I'd like to introduce you to Patricia, who is going to be our guide
Hello.
today. So Patricia, can you tell me a little bit about what the need was that prompted someone who had a vision clearly to make it happen and put it into action, and what challenges were required to overcome?
Yeah. So thank you, Patricia. And as mentioned, the need for this hospital 19 years ago that it has been in existence from 2003 when we were founded by our founder. He's called Dr. Scott Kellerman. He was Dr. Scott Kellerman. He was our founder. He was a physician from the US. He is a physician from the US. So he had come with the sole aim of helping out the pygmies who were the Batwa at the time. They had just been evicted from the forest.
And the Batwas are the pygmies, right?
Yes.
Yes.
Yeah, we call them the Batwa.
Yes,
local
absolutely.
language.
Yeah.
And then pygmies in the English. And so they had been evicted at a time from the forest, as it has been being gazetted for the mountain gorillas. So from the eviction, there was no plan at hand for the people that have been evicted from the forest, with their settlement, with their health. There was no plan at a time with the government to see where next, where are they going, how are they going to settle in the area. So that's how he came in. He was a missionary with the church, and then they came out to help this place with the pygmies. So he started this was a clinic which was just started under a tree, just before after our gate there. It was started under a tree, and it was a mobile clinic. Just going from where there is need, just carry your things and go to the people that you need. And so from then, he found out that it was not only the Batwa actually, all the pygmies that needed the help. Even the people in the community themselves, they are facing the same challenges. Healthcare, it was all over. So it's not only the Batwa that needed the help, but even the people in the communities themselves needed the same help. So he was like, we cannot constrain this to only Batwa.
Would be unfair.
When even people in the community also need the help. So it was opened up to people in the community, and from then he went back home. They sold a few of their properties. He came back with his wife Carol, and then they put up this first ever building with the help with the park.
Let's have a look.
This is the outpatient building that you're looking at. That we call it as the reception, where we receive our clients from. So from then, we have been fundraising with his efforts. He formed a charity in the US. It's called the Kellerman Foundation.
The which?
The Kellerman Foundation.
Kellerman?
Yeah, that's his last name, and then the foundation.
Scott Kellerman.
Yeah. So it's the Kellerman Foundation that has been helping to fundraise for our hospital all those years ago until today. And we've not only formed charities in the US, we have charities in different countries. We have a charity in the UK, which Bwindi we have in Germany, a few people and other people helping us, to get this where we are right now.
Absolutely.
Right now we are 150 bed capacity hospital.
150 beds.
Yes.
That is nothing.
And actually improving to around 150, around 155. But right now in our records, we are 150 bed capacity hospital right now.
Wow.
And with different departments.
That's an accomplishment.
Very, very big of an accomplishment over the years. And we have received different awards. If you could those are the different awards our hospital has been able to receive with the healthcare that we provide to the different people, and even in the region, and getting out different care that was not even there before that we are able to provide. So with the different departments, we have pediatric care, child health department, we have the neonatal unit in there with all, helping all the prematures, and actually this neonatal unit serves the whole region, all the western region.
Is premature birth a problem?
Yeah, it is, but as a hospital we try so much not to at least prevent a few with our ambulance services or outreach services. That we've had a collaboration with lower health centers, that in case there is an emergency, in case there is a problem or a complication, they just call upon us, and then just rush.
That's great.
Just rush
That's
there
great.
and get the woman to to our care here. But with all that, still we still have it as a challenge. But at least we, as a hospital, we are trying to save that bit of lives.
Absolutely. And
Yeah.
the quality of life of that baby, even if it lives,
Yeah.
if it's premature.
Yeah, so we protect the life of the mother and the child. They're all our priorities. And we've had reduced maternal death, and their mortality rates have totally reduced. So we've seen a lot of accomplishments during our years right here. And with the maternal health that we provide, we run our HIV clinic. We have services that we provide to the communities. So we have chronic. We have chronic care.
Chronic care as well.
Yeah, we have adult wards that we deal with general illnesses, malaria, pneumonia, any other chronic illnesses.
Could you show us around?
Yes,
Would
please.
you? Yeah,
Okay.
that would be
It'd be a
great.
pleasure to show you around.
It would be great.
So as a hospital to serve our community better, we came up with a local insurance scheme.
Oh,
Yes, as nationally in Uganda, we don't have an insurance.
I got health insurance.
Yes.
I love it.
So we came up with a local insurance scheme. It's called Equality. That's the offices in the container, as you see it.
Okay.
Yeah, that's called Equality Insurance Scheme. So how we do it is we went to the community or to the villages at the community level. So in different communities, there are these groups that help in time of grief. You've lost someone, and then in the community there is that group that comes together to help you, with those arrangements. So through those groups, we got their leaders, and then they can pay subscription through their group leader, and then they bring to the hospital. And then after that, you come to the hospital and pay a very small consultation.
Okay.
Which is, we pay $4,000. That's about $1, like $1 or something. And then you get the services.
Oh my goodness.
Yeah, so that has helped us, at least reach to our communities better, and then services, people coming for services better without fear of, ma'am, this price.
Yes. Yeah, and shame too if you can't pay your
How
way.
am I going to manage all these prices? But with our services here, they are very, very highly subsidized. It's a quarter of a quarter of a quarter that you would pay in any other
Absolutely.
hospital.
Absolutely.
So it's so much small that at least we try to encourage people to at least pay the consultation that are able. But there are those people or families that are not even able to pay the small consultation that they put in place. So that's why we came up with
I think that's a great idea.
with the Good Samaritan Fund that even staff themselves give to visitors, anybody, to just help those people that are not able to get any of those, to get their food while they're here or anything else.
Yes, the food
Yeah.
too, right?
So we have a community
And
health.
the medications.
And the medications, yeah. So we have a community health and batwa department right here. And all those motorcycles you're seeing, the nurses use them to go to the communities.
Oh, neat.
They ride them to the communities. So this is the outreach
That's
services
an
that
image.
I know. So that's why most of
I
the
love
office, what we have in there, we have around
love
6 male nurses. A female could ride.
Oh, they're all male nurses.
Yeah.
Oh,
A
okay.
female could
Okay.
ride. We could
Okay.
ride. But you see our texture or the place we live in, it might be difficult for a female to ride in there. So that's why we have those nurses that ride in the communities with a mental health clinic in there.
Oh my goodness.
Taking
mental
all
health
the
as well.
stuff. Yeah.
I'm going to get in the shade here.
Sorry. Taking all the services, to the communities.
Hello.
And all those people who are not able to reach the hospital, at least services can get to them in those places.
What kind of off-site services would you?
So whatever we give here at the hospital, we also take to the communities. For example, even though it's not the community nurses going out, we also have outreach programs that we run as a hospital, taking groups to communities.
Oh, okay.
So in that we provide family planning, we do cervical cancer screening, there's a lot of education, we take HIV services out there.
You're talking full service.
Yeah, full service. We take
Holy
them
Hannah.
to communities. Because whatever we have to provide here, we make sure that at least even people who are not able to reach here, they can able to get through those outreach communities. And with that, that's why we came up with satellite clinics We have satellite clinics at the
What is
edge.
it? Satellite.
Yeah, at the
Okay.
edge of the forest.
Okay.
And most people living at the edge of the forest,
is immense.
it's really hard for them to reach the hospital.
yeah.
So with our satellite clinics, we can serve people there. Our staffs here are the ones that are in the satellite clinics.
Mm-hmm.
So even the staffs at the satellite clinics are staffs of Bwindi Community Hospital.
Okay.
So every service that we are able to offer there, and if it's maybe a difficult or complicated condition, that's when they call us, and then we can go and pick the person
Wow.
now to the facility.
Okay.
Yeah, so that's how we do with outreaches, and then with our satellite clinics being there, and it has been really helpful because most people don't have any means of reaching here, and the most means
So you couldn't walk some of the
You know,
distances
it's
we've
too
driven. I
long.
can't imagine.
Yeah, and most of the means of services that we have here, it's by motorcycle, and so and lately they've been even so expensive. The economy being high, the fuels being high,
Fuel.
people are so difficult for people to reach here. So with our outreach communities, at least we reach people where they are right now.
Okay.
Yeah.
Yeah.
And this is the kitchen.
Love to see it.
You will love to see the kitchen. So people who are admitted on ward and they are sick,
This little tight. Oh my goodness.
no. The hospital is not able to provide for our patients meals.
Hello.
So
Hello.
the place, at least there is some lighting.
Yeah. No. This should be.
Yeah. So so if you have your attendant and you're at the hospital, they can be able to prepare food from here, and then they can bring you on ward.
Okay. So family can cook for you.
Yes, family can cook
That's
Because
an idea.
At the hospital, we're not able to provide food
Yeah.
for all the
Yeah.
patients.
No.
Yeah,
No.
So we encourage everyone that has come and they're admitted at ward. Someone is there to take care of them, an attendant, preferably family, that someone comes up to just take care of them. And if they don't bring food from home, cooked food from home, they can always bring raw food and then they can cook from here.
Okay.
That's why the kitchen is in place.
I heard babies crying.
That's the pediatric ward. That's why you're hearing babies.
Can
You
I
can
see babies?
pass through here.
Everybody loves babies.
I know. Watch the tape. So this is the pediatric ward. We call it the child health department. This is their play area, basically. And in here we admit children.
Perfect. It should be blinking. How did COVID affect everything?
So we were very much affected in this area, as you see, we're in an area that is a tourism area, and most of our help or funds or donations we have been able to get through, tourists, those who had come here. So during that period, it was really, really difficult for us to move on. With no tourists coming in, and then the funds were a little limited, and with us taking care of COVID patients, it was really difficult for the hospital. As I told you, we don't have an oxygen plant as a hospital, and you can imagine how much oxygen.
Oh my
those
goodness
patients
sakes.
Needed.
You have to have it trucked in. I don't believe
While
that.
we were here. So it was too much of a challenge that our car was on the road 24/7, carrying those cylinders that you saw to bring oxygen. It was really, really hard as a hospital, and that's why
Your finances must have taken a hit as well.
very much the salaries of our staffs were actually they were reduced salaries for all of us because it took a toll on us, the whole organization. And we are actually still recovering
I'll bet.
from that period.
I'll bet.
Because it was really kind of bad at that time. And of course, with the patients, we lost a few of our patients, but
Well, you would.
thank God we didn't lose any of our staff.
Oh,
Yeah, we didn't lose any of our staff because we were all affected.
oh.
We actually
The
all
fear must have been horrible.
horrible. It was very, very, very much horrible. And at the beginning, people did not understand how horrible or how bad
Yeah.
COVID
Transmissible it was.
until we started getting cases, even right here in the
You what?
hospital. Until we started getting cases,
Oh, yeah.
coming up and people being admitted here, and then you hear someone dying, and that's when the commotion came all over. Like, what is happening? And with us not having enough oxygen, struggling here and here, it was really
It'd be a terrible death.
It was a tough time for the hospital. And even with the staff getting sick, we got limited staff on ward, because if you gotten sick, you are going to be, closed off, taken off, and you're going to be in your room, you're not getting out. So even with that, even the staffs were
Mental
limited
health, yeah.
on ward. So with having limited staff, and then with the staffs who are there, you know, if they are not mentally
The mental health
in
was
place.
terrible.
So it was totally terrible. But
I remember even in our city, in our community, we are very privileged. We're very buffered from the worst of things. We get it, but you know, we're not sort of in the first thrust of it. And it felt like the plague. It felt like this invisible enemy, you know, that you couldn't see, and it was suspect everywhere. So I can't imagine
it was too much for
if
us.
you didn't
But
have those
as a
protections.
hospital, we tried to be there for the people. For example, for our HIV clients, because we were in lockdown everywhere, no one was moving, and the only privilege was health practitioners were able to move. And for example, HIV, we were able to take drugs to their homes. We come to your door and knock, like these are your drugs. You're not able to come, of course, to get your refill drugs. Any people with chronic illnesses, we are going up to their homes, you know, to take for them drugs, looking at, you know, children, taking our ambulances to get people. So it was really, really difficult. A toll on our finances,
Yeah.
a toll on our, you know, everything was. But now that we are actually, you know, out of the COVID and we're trying to recover, and then we hear of Ebola, but thankfully it also didn't reach the region. It also, we're a little scared that we're going back to how we are with the COVID, but thankfully we did not get any
Masks.
masks everywhere. It was a tough time. Generally for the hospital management, for the financials, for the day-to-day, you know, activities going on. It was generally very, 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 very difficult.
Thank you.
And as long as you're below 14 years of age, you're admitted on this ward. So we have babies here, we have, you know, at least children who have grown a little bit, around 8, 9. As long as you're below 14 years, you're admitted on this ward. Because see, kids are playing and they really enjoy their play area. So we make the place really child friendly. Even though you're sick, that at least a child needs to feel like they're at home and they're enjoying
safe.
themselves and they're safe. That's why we put a friendly environment. And in here, so as long as the child is admitted, there is someone to take care of them. It's mostly their mothers, of course, taking care of,
or aunties.
Yeah, and an auntie or an elder sister. I think someone who's able to take care of the children. And that is the kitchen where they teach mothers on how or what to prepare for, you know, children.
Nutrition.
And this is usually for, you know, for nutrition. And so they teach them on how. And
Is this an oxygen tent? The cover.
Is it? I'm not sure. We can ask the nurses right there.
Okay.
They'll be able to tell us what
Who did the artwork?
We have some guy that usually does our
Lovely.
artwork, and he was so good with the children's artwork.
It's very happy and
So
optimistic.
from the kitchen, we can just pass through here. And in here we have a neonatal unit.
A neonatal, okay.
Where now babies or prematures are, you know, admitted. I don't know if you have any of them.
Hello.
Hello. How are we? That is Cynthia. She's a nurse. She works in the pediatrics.
I've come from Canada to do a video on overcoming challenges, and this certainly was a challenge that you folks have just done an amazing job on. Yeah.
Do you have any babies?
We have 8.
Okay.
8
Would you be
babies.
able to, want to have a look at it?
Yes, I love it.
Since you can pass right in.
Can I pass there? Okay.
I have a premature one. So usually this is the section where we admit prematures and the section where we admit other babies with the neonatal sepsis and birth asphyxia. So we have one baby here. The others, I think you cannot be able to. Maybe in case you want to go in, we can go there.
Well, would you feel safe doing that? I am vaccinated 5 times.
Okay, fine.
Okay, that would be great.
Yeah, you can come.
Okay, yeah.
Oh, we have to leave our shoes here.
Yes. Oh, okay. All right, we're good. Okay. Hello. Beautiful baby.
Auntie Jackie. You can meet Sister Jackie.
Hi, Jackie. Nice to meet you.
Nice to meet you.
I'm Elaine. I've come from Canada to do a video on overcoming challenges.
You're welcome.
So she can take you through.
Okay.
I can take her.
She can. Come on, Jackie.
It's fine.
Come
You're
on.
welcome.
She looks like.
Hi, how are you? You're fine. Haven't I give you what to put on?
Okay. Can you get this? There we are. Let me show you when you're dressing up. Like,
Yes.
as you can see, how she's going into the pedois. Oh, that's a pause. Definitely a look. Thank you.
You're welcome to our neonatal unit.
Hello, I'm Elaine.
Nice to meet you. I'm Frances.
You're
Frances.
Frances. Nice to meet you, Frances.
She's our pediatrician.
I have a sister-in-law, Frances. Yeah.
Welcome to BCH.
Thanks.
I shall leave you to do your tour.
Oh, thank you very much.
See, Jackie, you're doing the tour.
This is our unit. It's divided into 3 units. There's the other one, and there's this one, and this one.
This little guy.
So, these are our incubators that we have, and we have 2 in here that we help to keep these babies warm. And
How premature was this baby?
28 weeks,
So normal's what, 42?
like 39, 37, 40.
Wow.
But this is 28 weeks. He's quite very, very ill. But we're trying our best to get him medications that he needs for his growth. Yeah. And we have this that require.
This little one.
This one is fine. He's due for discharge.
Is he?
Yes.
He's going
He's going
home.
home.
He's going home. You're going home.
The mother is already waiting.
But she can
father-
hardly wait.
Yes, they're going home. And this is on phototherapy.
Oh.
But she's doing quite well. We have that's our
Oxygen?
yeah, but to call it CPAP.
CPAP, right?
Yes, it gives continuous oxygen.
Mm-hmm.
We have only one in this unit. It's not good because we need multiple to be able to serve several. So the challenge comes in when we have many kids that need it and we have only one.
Mm-hmm.
So there.
What do they cost?
I'm not sure of the price.
Who would know?
But what we do usually when it's not there, we make a local CPAP for them.
Oh,
Yes. And we're able to provide for them still. Yeah, so this is the main unit. This one is warm for, because the babies are premature.
how premature was this baby?
This baby is at 7 weeks here.
7 weeks premature.
This baby was 27 weeks. 27, yeah. 27 weeks. But we'll survive. He's doing quite well now.
Mm-hmm.
Yeah. Yeah, so those that are born with birth asphyxia, we usually keep them in the other unit.
What is that?
Birth asphyxia is when you're born, like you don't have enough oxygen, and so we keep them the other side because the environment is quite cooler, and because if they're here, it's warm and they deteriorate more.
Okay.
So we separate them and keep them the other side. Also, still we keep those that were full term, not premature.
Right.
We keep them in there.
Okay.
So
How long do you hold them after birth? And what would cause them to come here to birth as opposed to home?
One, usually when they get sick, that is sepsis, they become sick from
Bacteria or
maternal
something?
infections. They come here. Like some mothers give birth to prematures because of hypertension, and then they just develop that. Even malaria can cause that. Yeah, so you define that the kids are born here. Kids that have had there's something we call meconium, aspiration.
Oh, yes.
Get
All
that
right.
in their mouth, and so
And the lungs.
yes, and their lungs, and they're unable to breathe. We bring them here. So there are quite really a number of reasons as well. And then this being the only neonatal unit in 3 big south
Countries.
countries.
Yeah.
So this is the only referral center
Wow.
in this region.
Wow.
That we have. So
Love to know what the CPAP costs. I know you can't possibly know that. But
Yeah.
who would know it?
the administrators.
Okay, we'll ask.
They're the ones who buy them.
We'll ask.
So this is the only one you can imagine. And
Locally,
we try to connect. This is actually not a CPAP. This is an oxygen.
Okay.
So this is an oxygen. We try to use a local thing to make a CPAP for the child. Yeah. So we don't have we don't have a CPAP machine. The one which we had was worn and it's faulty at the moment. Yeah.
Okay.
So
How many oxygen machines do you have?
we have 2, but we are lucky. We also have those that are on the wall, but we have this, and then this and other 2
Okay.
in the unit for
Okay.
now. So these are our babies that are fully grown.
Oh.
Mm.
These are the ones that are going to go home.
Yeah, these are fully grown babies.
Hello.
They're full term.
Hello.
Smile for
I think she did.
Yeah.
Oh my
almost
goodness.
Going home.
Look at this little guy. Hello. Clearly a little girl. Hello.
Yes.
Hello,
putting on
sweetheart.
pink.
How are you? She's a. Who is this person? Oh,
So thank you very much
oh, thank you.
for coming to
Thank
our
you,
unit.
guys.
You're welcome.
Thank you.
I felt like I wasn't dressed nicely
For the
because I didn't bring stuff.
I had
So,
you. I guess they're right there. I think.
the dress would be good.
Thank you, Jackie. Thank you so much.
Take care. Nice to meet you, Francis.
Can we undress you, please?
Yes, please.
Are you visiting lots of places?
I'm doing the hospital, and I went to the Ride for Women program. Yeah, so that's probably about. Can I? Would you hold that just for a second? Yeah.
The camera is
Is it on me? I'll point to Jackie.
And this is 360. So
Oh,
this
right.
is
So it's getting everything.
So we can't hide.
Take a bow. Thank you very much for making time for me.
Oh, you follow it.
that is great.
Hello.
Okay. How was?
It was very, very illuminating. I'd love to know how much a pediatric CPAP machine is.
Okay, we can find that out.
Yeah.
We can find out.
Yeah.
We had lots of quotations and everything. We could just find out that at the end of the tour.
Sure.
Yeah. So welcome from the pediatric ward
Yeah.
where we're heading to. This is the adult ward or medical ward.
All right. Medical.
Medical ward. And in here, like you saw, we admit children. Here we admit adults. And adults here mean over 14 years. You're gonna have to be an adult.
Would they mind being filmed?
I don't think they would. They
Sure.
have cameras.
Okay.
But in case we're gonna talk to someone or film someone, we just need to ask for their consent and just ask. But the ward is not that busy. I don't see anyone.
That means people are healthy. That's good news.
So in here we even have our ICU. Our ICU is in there. And these are a few private rooms. In case someone is not comfortable on the general ward, they can opt out to come to the private ward right there. And we also have other private rooms in there. So right here we admit general illnesses, malaria, pneumonia, chronic illnesses, everything is admitted in this ward. Yeah, and as long as you're an adult and you have been admitted from outpatient, they advise you going to be admitted for more care. You'll be admitted in this ward.
Is there a cost for them by day? Is there a fee for them by day to stay in the hospital?
There is a fee, but it depends on if you're in our insurance or not in insurance. So people who are in our insurance shall have different costs, and those who are in our insurance have a different cost. And so it has been in that, for example, if in the maternity ward, if you're in our hostel, you've been admitted, you're going to pay 5,000. That's your whole stay.
Okay.
Your whole stay. So it just depends on what condition.
5,000 would be equivalent to what in US?
That's $1 right now is around 3 cents. That's $1.
Okay.
Yeah.
And that would be if you have insurance or if you don't? If you don't have insurance, what would it be?
And then, for example, if you don't have insurance right here, you're going to pay 26,000 for just consultation. So 26,000, that's like $5.
Yeah. Is that a lot for people?
Yeah.
And can they make payments on it?
For the people that we serve in this community, that's quite a lot for them. And that's why we came up with insurance. That you're going to just pay 4,000. And that's why we encourage most of the people, to come in our insurance, to avoid all that. Because we want, by us getting the insurance on, we wanted you to access our service.
Well, it means you're more likely to come for care. You won't be as sick when you...
You won't stay home and be like, let me
Yeah.
just stay home, I think I'll get better, just on a thought.
Yeah.
But if you're in insurance, some people just come like, I feel a headache.
So yeah, we've got those too. So if you didn't have insurance and you had to pay the 26,000, can you pay that a little bit at a time?
So that is consultation. That's what you're going to pay right away.
Okay.
Yes.
Okay.
That's what you're going to pay right away before you're going to be seen by a clinician. You're going to be, and if it's like the 4,000, that's the first thing. They triage you and then you pay the 4,000, and then now a clinician can look at you. So that's the first thing that you're able to pay. So what you can pay in phases is when you're admitted here.
Okay. All right.
And then you'll be like, okay, we'll be getting the money in a few days. You're like, okay, that's when you can pay. And then you can even pay after you have been at discharge time.
Yeah, that's
So
humane.
yes,
They can budget for it. Nobody plans to get sick. This
so
is the
that gives
thing.
you a period of, like when you're admitted, that gives you a period for you to get the money and then you can
Yeah.
But then the 26 or the 4,000 is consultation fee. It is that what you're going to give us immediately when you
Well,
after
that
triage, you're going to pay.
yeah,
So that's when someone is planning, like, I'm going to the hospital, let me get a consultation fee. But then when I get admitted, the rest will come later. Yeah. But the consultation is just after triage.
Yeah, well, you've got to have a basic structure
you're gonna have
that you
something.
can count on in order to stay open. Yeah.
So with being admitted, that's when you plan, you pay, and people at home, be like, okay, let's go and look for something that we're going to pay after you have, on your discharge. Because the accounts team keeps coming, it tells you how much, you're supposed to pay.
For sure.
Just to get you prepared.
Yeah, that happens everywhere.
How you're going to pay.
Yeah.
Yeah.
Hello.
And it's usually not much, but because of the community
Well,
that we serve.
it's all relative to what you
mostly-
have.
Yeah, it's mostly subsistence. People are just farming, and mostly what they're doing for farming is it's for eating, just survival.
I know,
not even
I know.
for sale, for
I know.
someone to get something out of it. So, and it's really difficult, for people to get an income that can really sustain them in a way.
I would suppose that there aren't very many permanent, dependable, continuing jobs.
Yeah. Formally, maybe for the job, but that's not the community that we serve here. Most of the people that we serve here are basically subsistence farmers, either they are growing some tea or any other crops, and it's basically subsistence that are just going to eat what they are growing.
Yeah.
So they're just growing to survive, not that they're growing to get the money out of it. They're just growing to get something to eat.
Not a profit margin.
Not a profit margin. It's like a hospital. It's a non-profit.
Yeah.
So yeah, and this ward is basically surgical. This is the surgical ward, and we admit here surgical cases.
I won't go any closer because they might
You're either going to theater or after theater. This is where we
come to recuperate.
we admit you for preparation for anything after that. And we just begin them with this side is the male, the female side, and then the other side is just the male. And I don't know if we have any nurse there. You know, come there?
Yeah, I just don't want to intrude.
It's okay.
Hello.
We have some here.
Hello.
Hi, this is Elizabeth, and that's
Elizabeth, hello.
They work on the on the adult ward, and
Surgical
basically
ward.
the surgical ward. And Elizabeth would answer any of the questions you might have, or any other thing you might want to know.
Elizabeth, I'm doing a project from Canada on overcoming challenges on behalf of my clients. I'm a therapist in Canada dealing with hoarding disorder. It's a mental health disorder. And so I thought that I would come and do something I've never done before, that I'm not well prepared for, which was guerrilla trekking. And at the same time, just kind of do a survey in the community of other people, Dr. Scott, for instance, who had a vision because there was a need. And that vision carried with it a lot of challenges. And so what are the challenges for you as a healthcare provider in a surgical unit in Uganda?
Well, on the part of the patients, basically I think one of the challenges that we face, for example, if the services that we have to offer here are not enough for the patient and we have to send them off to somewhere, it is sometimes difficult for some of the patients who have financial challenges. So we end up not helping at all because we cannot do enough for them here and they still cannot
able to
afford
go to referral
to go to the referral facility because even our referral facilities are at times costly, even the transport costs
to get there.
so it is tough for them. Basically, that is it.
What's the end result for the people who can only get the I won't say initial because this is not initial, general level of care when they need specialized care? What's the end product? What's the end result for them?
So normally they go home
Usually they go home and wait for any instance.
and wait for whatever will come last.
Wait for what?
Whatever will come last.
Okay.
Which will
Yeah,
be the
no,
bad side of the
no, I
story.
understand. I know.
Yeah, so if you're not able to go to the referral facility, and then right here, what we can offer you is not that much that is going to help you out of the
It's not going to solve the
So
problem.
some people are like, let's just go home and prepare. Yeah, mostly for death. Yeah. And so it's a challenge to do that because there is nothing much you can do for your patient. You're feeling
should
sorry
know
for
more,
them,
but-
like you're supposed to do more, but
And
you
you,
cannot.
the real, I would think, as a trained healthcare provider as well, because I worked with Ottawa Public Health for 5 years as their social worker and community developer, and the trauma for you is that you know more care is available. You know there's a solution, and you can't open that door.
We can't because our hands are closed. Because if they don't have the financial support, I can do more or less for them as well.
What's the end result for you? Because that happens to them, not that it isn't important, it is very important. That happens to them once, but that happens to you over and over and over again. What is the end result for you?
For me, it is a challenge. It's not good to know that the patient has gone home to
Wait. Yeah.
So it also traumatizes me in a way because at times I feel like maybe I shouldn't receive those patients that will need more care than I can
Right.
afford.
Right. Yeah. It is a trauma. Really would be a trauma.
Because I know every time I get a patient who is not financially stable, there is almost nothing.
There's a limit. Yeah. There's a big limit, and you carry the limit because you have the knowledge. They don't actually have the knowledge, and so In some ways, it's a repeated trauma.
Let's help them as much as
Yeah.
we should,
Yeah.
or as we would.
Well, thank you for what you do. Yeah.
Thank you, Elizabeth.
Thank you. Excuse me. Okay. Don't want to.
What are you? So this, that's what we're heading for, operating theatre, and this right here, this is what we use to transport our oxygen to the hospital.
Oh.
At the hospital right now, we don't have an oxygen plant just to get oxygen and give to our patients.
You have to
So
buy
now
it?
we have to buy and transport this on the road to get oxygen now to the hospital. I know.
Okay. Hello. Oh, I'm so sorry. I stepped on you. Hello.
What is
Hello.
your X-ray?
Hello.
Hey. When mama every day. Hey. So that's our X-ray in there. With our radiology, we have a radiologist that runs both X-ray and scan. You wanna come in?
Sure.
So because he runs both X-ray and the scan the other side, so it's definitely when he may not even be able to find him on site when he's doing scans.
That's
that-
okay.
that
That's
side.
okay. He's got
But
work
that's
to do.
our fixed X-ray machine that helps patients who are able to be brought from the ward, that can be able to walk or be brought. They can use that fixed
For
X-ray machine.
diagnosis.
Yeah, but we have a portable X-ray that in case a patient is not able to come here, they can just take it to the ward and find
Oh,
it there.
lovely.
Yeah.
Good. That's good.
The camera still
Yep.
okay?
Yep. Camera's still blinking.
So we have our pharmacy, which is in a container.
Oh my goodness, I have to get this one. My sister-in-law was a nurse who set up. Yeah, no, I was just wanted to get the bigger picture of it. Yeah. My brother built hospitals in Kenya, and his wife is a nurse, and she would set up the pharmacy and help them learn how to manage.
Okay.
Yeah,
So
yeah.
this is like our main pharmacy right here. So patients, or the nurses at outpatient who give the drugs to the patients now, they pick drugs from here, which is like the main store, and take to outpatient or the pharmacy to give out to the clients. We
Right.
have a system that runs all this. We run it through a system. Different wards or different nurses at the different wards, they send in their requests through the system. So by the time they come to pick them,
I noticed the computer.
Yeah, they've already been arranged. They've already been, they've seen what they need, and everything is arranged. So a nurse comes from ward, and then they just pick the drugs from here. So that's how the system
Yeah,
works. They have
yeah.
different days on how you're going to request for drugs. They also have a system of, what we have in stock, but it's almost out of stock. So that's how they are doing.
Okay.
Yeah, we have class A drugs that are usually in drawers and everything. Methadone, anything that could be a little bit dangerous. So that's how we do it with
Lovely.
with the pharmacy.
I'll follow you.
I'll just put it down.
Yes, lock the door.
So this is our operating theatre. Right now we are refurbishing that other room for another X-ray machine that we just got, and we have to make that room into a room that can accommodate the machine. So that's why they're doing all that.
Installing it. Yep.
Yeah.
Are they operating?
No, this is the reception. They don't operate from here. We have to remove our shoes. We don't have to remove our shoes.
Hello.
Could remove the shoes?
Yes, I can. Sure. Oh, thank you. I'm better in I've got a left ankle that I've broken twice, so I'm better when I know the flat surface.
Okay.
Hello.
So you're most welcome
This is the theater.
Hello.
So this is the reception, and they're having breakfast, as you can see. So these are like working theater, not only theater, but even outside
Right.
theater. You want to say hello?
Yes. Hi, I'm Elaine Birchall. I've come from Canada to do a video on overcoming challenges. And having worked with Ottawa Public Health as their one lone social worker and community developer, I wanted to do a tour of your hospital to identify, what great work you are doing and what the needs are, what challenges you find you need to overcome, and whether there are the answers for you. And who knows who will see this. This video is going to go on social media. It's going to be posted on my website. And everybody who tracked on the 3 treks I've done, everybody wants a copy of all of the videos. So lots of people will see it. Yeah. Yeah.
Thank you very much. And we have our surgeon. Our surgeon is right there. He's called Dr. Daniel.
Hi, Dr. Yeah.
And we have Dr. Alex. These are both Dr. Alexes.
Oh, you've got a double Dr.
Yeah,
Alex.
we have a double Dr. Alex, and we are nurses that work with them, and our anesthetist is called Kule. So in case you need any questions or...
I guess just one question, and that is, what are the challenges that you face as physicians in a...
Dr. Daniel can answer that.
That will take a while.
That would take a while. That's okay. I've got a little power in the camera here. It's still blinking. What would you say your top 3 challenges are?
Personally,
You have to speak up though, because you have to hit the microphone.
I could take you to where my challenge is though.
Yeah. Okay.
Yeah, surgical.
Yeah.
Yes.
There's a negotiation going on right now. I have no idea what they're saying, but they're working it out.
Yeah, he'll be able to answer.
So I wanted to show you,
Yes, absolutely.
but they said you've seen it.
From the
surgical
surgical
ward.
Oh, the surgical ward. Yes, yes. Yeah.
She talked a little
Did
bit.
she show you that there's a limited space
Mm-hmm.
in the ward?
Yeah, I
You
was
see
looking
the
at the number of
area.
beds.
Yes, number of beds is too high for the small space. It's not so private. No one wants to be out in the open like that as a patient. So, but because we do not have the space, we cannot really partition that much.
The
And
option.
we have the numbers. The numbers are big, so we would need a bigger space just for one. The biggest challenge, though, is that the patients come in and they cannot afford the services. And that is I would say, the biggest challenge. So even when the services are subsidized, they still cannot afford them. So they will come in and you tell them about the service, and then they think about how much they would pay, and then they have to go back. Then they'll never come back.
Yeah.
And some of them they have problems that actually get worse with time.
Yeah, result in death.
Yeah, so instead of when they come back later, it's much worse. Some of them have cancer is advancing. Some of them have wounds which are getting much more complicated. So in the end, they become disabled.
Yes,
And
yes.
then sometimes when they come back, there's nothing you can do about their
Yeah.
condition anyway.
That's right. It's past help.
Yeah.
What is the cost to you? I'm not talking financial, but what is the cost to you? I know this having worked with physicians and nurses in public health, and I'm wondering whether it's the same for you, that that a remedy or at least a treatment that gives the opportunity for some level of solution, maybe not perfect, but a lot better than the person is now, is possible. It's available, but funds or access, because of it's geographically too far for them to get to. What is the residual cost to you as a surgeon?
I mean,
How does that impact you emotionally and psychologically too? Like,
of course it's sad.
the physicians I worked with manage their feelings. All right. What they can't do is manage their emotions because it registers. They're human beings. What is that like for you?
I would say about the same. It's hard to quantify really. So of course, you may not notice that it might be taking a toll on you. It's really hard to put in words or in figures. So, but it's challenging if you see it every day, and we do see it every day.
Yeah.
And there's not much you can do. You can't go out of pocket and pay for someone.
You
or
couldn't.
For everyone. So.
It would, yeah. How could you? Because you can't. What you do for one, you can't do for all.
Yeah, exactly.
Yeah. No.
Yeah, and for everyone that's here, it's already a sacrifice to come here, because most people's families are maybe 200 kilometers away, 300 kilometers away. So they are sacrificing to be here, and then to witness that on a regular basis can take a toll on someone.
No, for sure.
Yeah.
It takes a lot of courage to keep going. I know it does. Yeah. Yeah. Thank you very much for your time.
I hope she can show you the road again.
Yeah.
One last time.
I want to know how much the pediatric CPAP machine costs.
Yeah, we're gonna know after this over.
We might do some fundraising if we can. Yeah.
Thank you.
Yeah.
Thank you, doctor.
Thank you, everybody. Enjoy your breakfast. Okay. That was on. Okay. Thank you. Still blinking.
So we'll be heading right here. We are almost in summarizing the hospital.
Almost what?
Almost done.
Okay. Okay.
Where we're heading,
205.
we call it the section reproductive health, and that's basically the maternity
003.
ward for the women. And so this is the parts. Every service that we offer to women is offered in these parts.
Okay.
In this department.
Forgive
That
me,
is called
205,
sexual and
006.
reproductive health. And all the other services that we offer. So that
Yes, sir.
building, we could reach there. I'm sorry about
That's okay.
overwalking you.
That's all right. I got to get ready for tomorrow. Again.
I'll be tracking again
Yeah,
tomorrow.
tomorrow.
So this is the waiting hostel. Let me just be good for the camera.
Okay.
So this is the waiting mother's home, and we have around 38 beds in here. So with the mother's waiting home,
Are they waiting to give birth?
yes,
Okay.
exactly. So we just get what it is from how they call it. So people come here just to wait to give birth.
Now, would this be give birth generally, or give birth because it's anticipated that there might be a complication?
So that's part of the reason, and some of them are advised by a midwife or doctor to come and stay here because of the complicated pregnancy or any other risks that you might be not able to, they anticipate for you to get.
What would the other risks?
So they tell them to come here for them to regularly check on them. Like some of them who have had a few miscarriages before, who have had other problems. So they tell them to come in, before, and then they want to regularly look at them. That's one of the reasons. The other reason is some of them just come because they stay further away from the hospital. They just want to be prepared. Come from their places, and then they just come here, wait a few days, maybe 5 days, and and then they can give back.
Okay.
So it depends on any other reason, but it's mostly that they are advised to come, or others just come from further away and they just want you to be prepared.
Yeah, for sure. And I guess the more remote you are, the more
complications.
it could be.
And
And a
even
first birth
our
too, you
women
don't know
when they
how
are-
it will be.
Even our women when they are home, it doesn't matter how the pregnancy, how many months you have, they're still gonna work. And you've seen how our hills are. They're still going to go farming. They're still gonna do all of this work. So if someone has a complicated pregnancy, it may be very difficult for them
Yeah.
to keep up. So that's why we tell them just come.
Yeah,
here
come.
and wait.
Okay.
Yeah. And while they are waiting, we don't want them redundant. Ever in town or doing that, we engage them in a few activities while they're here. We have an instructor that teaches them, skills. They can do crafts. They can, do a little bit of, table mats. They can make baby's clothes. You can make your baby a heart. You can make your baby a sweater. Just to keep them.
A sweater.
Yes, sweater.
You need sweaters in this climate.
Is it a hot? Yeah, we need sweaters. It's usually really cold.
Welcome to Canada. That was funny, folks.
For you it is normal. Here it is cold.
Here it's cold. Come on.
Oh, this isn't normal. This is deadly hot.
Yeah.
Yeah.
we are getting some sunshine, but it has not been like this for the past month.
This is summer for us.
Oh, God.
This is as good as it gets.
Yeah, so they engage in those different activities just to keep them busy, not even to think much of what they've left at home.
Yeah,
just
yeah, yeah.
leave them focused. Hello. Hello.
Hello.
So this is Bwindi. She's a midwife and she's in charge of this ward.
Ah,
Yeah.
hello, Goodwin. Nice to meet you.
Nice to meet you.
Can you explain?
Okay. So she's making a few videos of our hospital while on tour, and she has been making videos even when she was tracking, just to see how we do and which challenges we face right here. And you never know from the videos what we may get out of this.
There's going to be quite a distribution. Yeah.
So
Yeah.
we do on her social media platforms, it will be everywhere for anyone to see what we do, and you never know, you can get a little help from that. You're welcome. So would you love to ask her any questions?
So, what do you find are the top 3 challenges for you with this ward?
In this ward, mostly, we face a challenge whereby, for example, in the last 2-3 years behind, we used to have many deliveries, but currently deliveries have reduced. We used to have like on average 150 deliveries, but currently the range is in 90s. Mothers are no longer, the average is 90. Mothers are no longer coming to deliver because our catchment area here, mothers are poor, they are able to come to the hospital. They say they don't have enough money to come and pay off for hospital bills, so they tend to deliver in their homes. They tend to deliver from lower health facilities whereby they get complications and maybe sometimes we pick them. But the most challenge is those mothers deliver from home, whereby when the mother delivers from home, it is difficult.
Is discouraged?
Yeah, it is difficult for them.
Difficult.
Because some of the babies have died from home, and we just get to know after some days that the
Oh
baby
my
died.
God.
Because the mother was delivering from home, she would not help. Maybe if they don't have help anywhere, and they don't get any help from other people, like the skills will be.
Everybody's surviving, basically.
True.
Just-
Then other challenges, maybe they come in late. Some mothers come in late here because they come from far. They come in late here. Reaching here, their babies are already tired from inside, and then we find it difficult to care for these babies.
Oh.
Babies are born with this stress, whereby after some time, this baby is not going to be like a normal baby who has been delivered
Who had a chance?
in health workers' hands who have been monitored by us. So that is also a challenge.
What does that do to you to see that hurdle, that challenge that they face, and that it's a very real obstacle for them? They're not negligent, they're not uninformed, but money.
What
Money.
we do currently, is educating them throughout antenatal. They come here for antenatal visits. That is care given to a pregnant woman from 0 day, from the time she knows that she's pregnant until she delivers. So when they come for antenatal, what we do is we educate them. But we tell them about birth preparedness. We tell them to get prepared, look for that small money. We also have a hostel, I think Sister Patricia told you about the hostel, the waiting area. We encourage them to look for some money to help them come in the hospital very early, to come use the hostel land, whereby to come and stay here in the hostel, such that when they are here in hostel, we keep checking on them daily, checking on the babies daily, and then in case the mother gets into labor, she is in the
She's ready.
hands.
Yeah.
We just pick her there, or she comes here in labor ward, we keep monitoring the babies, and then if they come here for antenatal, we try to educate them on the danger signs in pregnancy, such that when she's home and maybe any problem happens, she knows that
what it
it's
is.
a problem already.
Yeah.
She has to come to the hospital.
Yeah.
But if they don't come for antenatal, then it is a challenge. That is what we are doing, educating them, telling them about the danger signs, and encouraging them to come in the mother's waiting hostel for immediate care in case of anything. And then still we encourage them to have some small businesses.
To sustain them,
Yeah,
the costs.
to maintain them, to get the money to cater for their health.
Do you lose many mothers?
No, I think we lost a mother like 5 years ago. We were
At home.
Maternal death rarely. The challenge is maybe we get the neonatal death.
You get the what?
Neonatal death, the baby dies
Oh, okay.
after delivery.
Ah.
Yeah, after delivery or dies inside the just because they are not aware of the danger signs. Those who don't come to come for antenatal are not aware of the danger signs.
No,
so
no.
whatever happens, we can't tell. The woman just comes here, yet the baby has died already inside, or she comes here when the baby is already tired. On delivery, the baby is very
Distressed,
tired, distressed. After delivery, we take them to neonatal unit. They are in big ward. Some of them end up dying, which is absurd. But for the maternal death, rarely. Because the team we have here is very equipped with enough knowledge.
Yeah.
In case of anything, in case of any complication in pregnancy, we are already aware, we know we have that enough knowledge to care or to care for these mothers. So as to prevent those maternal.
Thank you for the work you do under the stresses. It takes a lot of courage.
Yeah, of course, but sometimes,
Yeah.
work for this woman.
I know.
Appreciate and say thank you. Appreciating is not getting money to pay to us, but
Yeah.
maybe saying thank you. Instead, someone even abuses you. You say, what? You're just helping her, which is okay. Psychologically, for us, we are fine. So what we do is trying to cancel them.
Yeah, for sure.
But we need to be if you can take her around.
Thank you.
It is okay. Patricia here is asking me if I can take you around.
Yeah, sure. Okay. I'll follow you.
Yeah, it's okay. This is our labor suit. This is our labor suit. This is where the mothers deliver from.
And
We have
do families come with them to assist with the
Yes,
delivery?
we encourage the attendants to come with them. That is either it can be a mother, it can be a mother, real mother, mother-in-law, a sister, sister-in-law, which is okay. In the case of anything, they are always there outside waiting. In case of anything, we call them for assistance. So we have 4 rooms. Labor ward rooms or delivery rooms.
Okay.
Whatever you see here is in all the rooms you're seeing outside there. This is our delivery room. Have a delivery bed. These are the things
I remember
we
it
use.
well.
You remember very well. So these are the things we use in labor suit. This is our bed. After the mother sleeps here, those are the waste bins. So what we do after delivering, she delivers from here. We bring the instruments. These are the things we use. We just get a baby and take her to the resuscitator where we do the neonatal care from.
What do you do if you need a cesarean, if you discover you need a
In
cesarean?
case of any cesarean section, in case we have identified the mother for cesarean section, we have a theater the other side.
And do you-
We don't have an immediate theater for maternal ward, which is a need, by the way. It is a need because sometimes if you get that complication that is very serious, that needs immediate cesarean section, sometimes it's difficult because we have to bring away
I know.
that drive a woman
I know.
to the other theater.
I know. I can't imagine.
So we just take
Yeah.
them to theater.
I can't imagine.
You can-
Whoa.
So this is where we receive our babies from this.
And you weigh them, of
room. This is
course.
where we do the resuscitation from.
Lovely.
And these are the equipment we use. We have our emergency crash cart.
Your crash cart,
A
yeah.
crash cart that is movable. In case of anything, whatever, wherever the woman is, we just drive it and take it.
Yep, yep.
Care for this woman.
I've seen crash cart.
Yeah, so this is our first room. We have our HD or high dependence unit here.
Hi, what?
high dependence unit.
High dependence?
Yes.
What does that mean?
HDU, where it might, I would be saying that ICU.
Okay.
Yeah, but it's not well equipped. But in case you get any mother, any very serious complicated case, this is where I would.
Okay. You have 2 beds.
We have 3 beds.
3 beds.
Yeah, we have 3 beds.
Wow.
This is for the disabled. We got it.
This is for the
The disabled mothers.
disabled.
Yeah, the disabled.
We haven't even
mothers.
thought of that.
We rarely, we just get one in 2 years. That's why it is here. But in case you get that case, this is the bed we use. So immediately from theater, this is where we take that. This is where we bring the mothers for immediate care, for close monitoring. From here, we take them to the other side for continuous monitoring.
So mostly guides or staff.
We have different departments, we have different subunits and the sexual and reproductive health. We have this as a PMTCT room, prevention of mother to child transmission of HIV. This is the clinic, this is where we care those babies from and their mothers, the HIV positive women and their babies.
How often would that happen?
We will always, like, of the 90 deliveries, like I was telling you, we only get like 6. On average, you get 5. And on average, you get 5 HIV positive mothers.
And do they know they're HIV positive
Yes.
before they do the blood test and know they're
Yes,
pregnant?
in antenatal, immediately when you start doing the antenatal care, we do all investigations to find out, does this woman have HIV? Does this woman have syphilis? Does she have gonorrhea? Like those tests, hepatitis B.
Yeah.
So already she knows that she's HIV positive. Without antenatal, we teach them and tell them exactly what to do. Immediately after delivery, we give the drug to the baby and the mother, and then she continues in this clinic.
Okay.
Then room 19 is the postnatal care room. Postnatal care is care given to the mother after delivery, immediate after delivery, up to 6 to 8 weeks. So this is the room where we examine them from. We tell them after discharge, we tell them to come back at 6 days, 6 weeks, and 6 months. So when they come back, that is the room we use for continuous monitoring and examination until they are discharged. Then this one here, room 17 is the family planning room. We offer all family planning services. We have the short-term and long-term services. So this is
Short term would be what?
so those are the methods that just take a short time.
Like
3
condoms.
months, condoms,
Okay.
emergency pills. Then for the long term, we have those ones that last 3 years, 5 years.
Are they
and 10
injections?
years. The injections are the ones of 3 months.
Okay. What are the others?
The others are implants. They can be inserted under the skin. Then the one of 10 years is an intrauterine device, the one we put in the.
And how many women opt for that?
Of the average 90 deliveries we have, a few of them say postpartum family planning. On average, we get like 40. Like 40 of them
Okay.
take family planning.
Okay.
As postpartum. So what they do, sometimes these women tend to fear using family planning because of the myth and misconception.
Yes. And the injunction too.
Yes. So what we do, we try to counsel them, we try to educate them about the family planning.
And do you incorporate the planning and the information with their husbands or partners?
Yes, when they are around, when she comes with the husband, we are even happy by the way, because you know when you give this implant to this woman and she goes home, and the husband does not want never wanted the woman to use the method, it is going to be a struggle in the family. So what we do, we try to counsel the couple for all of them to know about the side effects of the method, so that in case of anything, the husband is willing to help her out. If it is to come back to the hospital to change a method, to switch to another method, he's going to help her out. He's going to support her.
Is there a lot of support among
Yes,
partners?
they are supported by their partners.
A lot?
Yes.
Okay.
Only that is a challenge. Some of them tend to be busy in their housework. They be like, you go alone. So rarely they come with their husband, but rarely they come. We only like 5% support their partners.
Okay.
We even have cancer screening services.
You have what?
Cancer screening, cervical cancer screening. Cervical cancer.
Cervical cancer.
Yeah,
Okay. Yep.
screening. This is the room where we offer the services from. It opens daily, Monday to Saturday. All women eligible for cancer screening, for cervical cancer screening, are aware this is the room we use. Only that people still tend to fear to be screened because they fear that the procedure is hectic. But after counseling them, after knowing how we do the procedure, they are happy. They come and pick up.
Do you screen or have a program for young women with HPV?
Yes, we have those services here. We do immunization for those young
Good.
women to prevent the cervical cancer.
Yeah.
We have a department, community department that does immunization.
Okay.
We still take them on post-go causes of cervical cancer. We have youth-friendly services.
Oh, good.
Youth-friendly services, it's where we do all the services. We even educate them in outpatient department. We find them in the community. By the way, we always find them in communities. Tell them about these services. We take the family planning services, cancer screening services, antenatal services, dental services, eye services.
No kidding.
We have an integrated outreach that is 4 outreaches in the month.
Okay.
We find them in the community. Then this antenatal care room I was telling you about where those mothers who are pregnant come for checkup from immediately when they tend to be pregnant until they are to deliver. So this is the room where we examine them.
Okay. Hello.
Any other questions?
No, I'm good. You're doing very well.
Thank you very much.
And so this is
the postnatal room. This is where we bring our postnatal, those ones who have just delivered, immediate after delivery up to 6 weeks. In case she has any concerns, any complication, this is the way we bring them. After delivering, this is where immediately.
congratulations.
Baby.
Happy baby.
After delivering from the other side, from labor ward, we bring them here to rest and continuous monitoring. This is where we examine.
Good.
Those ones who have delivered, those ones who have other complications like malaria in pregnancy, urinary tract infections, this is the room we use.
Okay.
We still have a small space, otherwise we would be separating those conditions from those ones who have delivered. But now that the space is still small, we mix them.
Yeah, for sure. This is
We mix
ample.
them.
Yeah. Okay.
So that is all about our section.
Thank you.
I now hand over to you. Thank you so much.
Hand off.
Welcome.
Thank you so much.
Welcome.
Thank you so much for your time.
Welcome.
Did you have a good time?
I had a wonderful time. I'm glad this is happening for somebody else. I'm so past this. I have 2 children.
Wow, that's great.
Yeah, 2 children you have. You have to have 2 children. It sounds like you have only 2 children.
I know.
Are you serious?
It was deliberate. Yeah. 2 children, 2 hands.
So we are left with our HIV, building, and I think we'll get there.
Babies. Hello. Hello.
our HIV clinic right here. And so every HIV, we give every HIV services happens in this building. And if we make it a little private, that in case an HIV patient comes in,
Absolutely.
they don't have to wait at the reception like the rest. So they just have to come in directly and talk to their counselor. If they're getting drug refills, they can get drug refills. If they want to talk to a counselor, they can. That's our TB clinic. That's their dispensary.
Oh, you've got TB as well?
Yeah, that's the dispensary and the laboratory. Ken, can I talk to you? This is the in charge of the HIV department.
Hello, Ken. Hello. My name's Elaine. I've come from Canada. I'm doing a video for the project Overcoming Challenges. And when I heard about your hospital, I wanted to include it. And it'll be on all social media and on my website. So a lot of people will see it.
So he's Kennedy. He heads the HIV department where we are right now.
Yeah.
In case you want to ask any questions or how many patients they would have in the clinic, what they are facing, he will be able to answer.
How do they get referred to you? How do your clients get referred to you?
We have community health volunteers who are trained to identify different clients who need services, especially those who present with signs and symptoms of TB or